Okay. Good morning, good afternoon, or good evening, everyone. So it's a pleasure to welcome you to the second Web Impact webinar for 2025. Today's topic is Bridging the Gap, Implementation Science Solutions in Practice for Cardiovascular Disease. So my name is Dr. Sarah Sahal. I'm a postdoctoral fellow at the University of Geneva, where we're utilizing implementation science to implement interventions to support patient medication adherence. Before we get started, we're just going to cover a few housekeeping points. So during the presentation, you'll all be muted. However, you are free to send comments or send questions in the chat function at any time. Following the presentation, we'll have a discussion session. And at that point, you can ask further questions either by raising up a hand signal or by entering your questions into the chat function also. Before each question is asked, I will ask the author if they want to personally, verbally ask the question to Professor Masterson Creber. If you don't wish to read out your question and you'd rather myself do it, please just indicate that in the comment. Okay. So now it's with great pleasure that I introduce you to Professor Masterson Creber. So she joins us today. She's a Mary Crawford Professor of Nursing at Columbia University. Her research focuses on improving the quality of life for cardiac patients and advancing healthcare delivery. She leads research on mobile integrated health interventions for heart failure, utilizing community paramedics and telemedicine to enhance transitions from hospital to home. Additionally, she directs global clinical trials across 70 hospitals to assess coronary bypass graft surgery outcomes. She is a fellow of the American Academy of Nursing and the American Heart Association and has received numerous accolades, including induction into the Sigma Theta Tau International Hall of Fame. Professor Masterson Creber holds degrees from the University of Pennsylvania, the London School of Hygiene and Tropical Medicine, with postdoctoral training at Columbia University. So her research has really significantly impacted cardiac care, and we're really lucky to have her here with us today and to present her latest work. So Professor Masterson Creber, the floor is yours.
Thank you, and thank you for that generous introduction. It's a huge pleasure to be here today to speak to all of you. And just following up, I welcome feedback and questions. So please feel free to put them in the chat. After this brief presentation, we'll be able to open it up for discussion. I'm really hoping for some robust dialogue at that time. So with that, I'm going to go ahead and jump right in. I have been working on a project. It's called the Mighty Heart Trial, and that's something I want to share a little bit with you today. The purpose of this is really to be able to be improving the delivery of cardiovascular care to patients when they go from the hospital to the home. And the disease population I want to talk about today is heart failure. Heart failure is a very common cardiovascular condition that impacts over 64 million people globally, and it has really high mortality, morbidity, and it's associated with poor quality of life for patients. I didn't mention this on the slide here, but it's also very costly because so much of the care for patients with heart failure is pushed into the acute care setting. And in the United States specifically, we have a challenge with many patients with heart failure having really uncontrolled symptoms. And some of those symptoms include shortness of breath, fatigue, peripheral edema, but many patients come back to the hospital over and over again. And so because of this, many hospitals have been trying to figure out what's the best way of providing care for patients when they go from the hospital back into the home. We call this a post-acute transition period. And because 25% of patients with heart failure are readmitted within 30 days. So this is a big area for being able to improve. We estimate that 80% of these hospitalizations could be prevented with better care at home. Some of the reasons that patients are coming back in right after getting readmitted are because it's difficult for them to get follow-up appointments with specialty care like cardiology. There's poor coordinations across settings, once again, from the hospital into the home, making sure that patients get their medications from the hospital when they get back home. There's a big gap there. And then there's many patient and structural level barriers that patients have, including lack of transportation to be able to go to medical appointments or to be able to go to the pharmacy to get their medications filled. There are barriers around patients' own health literacy or digital literacy, and that prevents many patients from routinely being able to access their healthcare professionals using modalities like telehealth. And so, for that reason, we designed a pragmatic randomized control trial. What we were interested in is really being able to look at real world interventions in a comparative effectiveness way to be able to compare two different post-acute transitions programs for patients with heart failure across two different health systems, which implemented the same interventions a little bit differently. These were conducted across 11 hospitals, like I mentioned, in two different health systems across the 5 boroughs of New York City. The first intervention was called a Transitions of Care Coordinator, and we compared that to another one called Mobile Integrated Health. So, Transitions of Care Coordinator, at hospital discharge, patients would receive a nurse coordinator phone call, and this would be about 48 to 72 hours. And nurses would call patients and talk to them about their medications, their follow-up appointments, their symptoms, a number of different things in a structured interview with patients. So that was one group. And that is a very common intervention that's implemented across many hospitals in the United States today. The second group, a second intervention, once again, that was ongoing in both of these hospital systems, is called Mobile Integrated Health. The differences here are patients still at discharge receive that nurse care coordinator phone call 48 to 72 hours after discharge. But in addition to that phone call, the nurse would triage patients and, if needed, could dispatch a community paramedic. That community paramedic would go into the patient's home and they would do their own assessment of the patient. And I'm going to show you a quick video of that in a minute so that you can really understand what I'm meaning here. They would do a fall assessment, make sure that patients had access to their medications, they would do a med reconciliation, and then they would do a facilitated telehealth visit. And this means they brought in all the equipment that was needed in order to do a telehealth visit. They brought laptops, tablets, and even hotspots because we didn't want to make any assumptions about the type of technology that patients had access to in their home. Because we know that for many of our most vulnerable patients with heart failure, they don't have the digital literacy to be able to use telehealth, or they don't have the technology or the devices to be able to do telehealth. So the community paramedic, they facilitate the telehealth visit. And then after that, the notes from that visit get sent to the patient's providers, their health team, and the nurse care coordinator then continues to follow up with that patient as needed. And if required, can send those paramedics back into the home again. So as you can see, this is really intended to try and close the loop in that post-discharge period. Okay, and so now what I'm going to do is I'm actually going to share with you a video. Minute. Just a second. One second. Okay, of the program.
The NYP Community Teleparamedicine Program combines paramedics' home visits with telemedicine to provide acute, unscheduled care throughout Brooklyn, the Bronx, Manhattan, and Queens.
Taking all your medicines? Okay, no changes, right?
Can somebody just tell me, can you see my screen okay?
So I think, Ruth, you might have reshared the slide, but rather than the web page, but that's okay.
Okay,
We
no,
can quickly fix that up.
Let me just quickly share that one more time. Okay, can you guys see this now?
Perfect.
Okay, great. We'll just replay that. Thank you.
The Community Teleparamedicine Program combines paramedics' home visits with telemedicine to provide acute, unscheduled care throughout Brooklyn, the Bronx, Manhattan, and Queens.
Taking all your medicines? Okay, no changes, right? No.
In the home, CTP performs a standardized assessment, including vital signs, physical exam, and cardiac monitoring. They ensure patients are taking the correct medications, review discharge instructions, provide disease education, and finally, using our telehealth equipment, initiate a virtual visit with an NYP emergency medicine doctor.
Hello? Hi, Dr. Nayak. She's looking pretty good. She's only complaining about that she's gained 2 pounds. However, she had lost 2 pounds. Right. Right?
I gained 2 pounds.
But if you look at her weight chart, yeah, she went from 157 to 155 and then came back up to 157.
Right. So I gained 2 pounds.
And the last time we saw her, she was 158. So I'm not concerned about that.
Our emergency doctors can access all of the patient's health records, prescribe new medications electronically, direct the medics to administer medications in the home for current symptoms, or send referrals to other NYP specialists.
Let me just confirm the pharmacy. It's the Walgreens on 2nd Avenue.
Yeah.
Okay, so I'm sending the refill for the metoprolol there. She can keep using the Cepacol throat lozenges as she needs to for that tickle. And then just follow up with her doctors.
CTP coordinates outpatient care by sending visit summaries to the healthcare team, contacting their regular doctors during a visit if necessary, and helping to arrange for home services or transportation.
I'm happy to see what we're seeing. I think you're doing okay.
Thank you, doctor.
Ms. Forkowitz, it was a pleasure meeting you.
Thank you.
You take care of yourself and we'll see you soon.
Okay.
Great. So hopefully that gave you a little bit of a clearer picture of what this mobile integrated health program is. So now what I want to move to is talking about how we evaluated the mobile integrated health program. We grounded our evaluation in the REAIM framework. Now, the REAIM framework, it might be something that you're very familiar with, but it's a widely used implementation science model designed to evaluate the impact and translation of health interventions into real-world settings. And it consists of 5 key dimensions. And I'm going to talk about each of these dimensions in the context of the mobile integrated health intervention in a moment. So the first construct is reach. And this is really focused on the proportion and representativeness of the individuals who participated in the intervention. Did we reach the population that we intended to? Effectiveness, and this could be effectiveness or efficacy, but in our case, with a pragmatic randomized trial, we're focusing on effectiveness. It's really the impact of the intervention on important outcomes. And for us in this context, primary outcomes were health status and hospitalization, but we're also looking at a number of other patient-reported outcomes as well. Adoption focuses on the proportion and representatives of the settings and the staff who are willing to initiate the intervention. Implementation is on the fidelity, the consistency of the intervention as intended. And then maintenance is the sustainability. Right? Is it able to be sustained over time after the research evaluation is completed? So for each of these constructs, we looked at different data. And I share this with you because as you think about designing your own study or evaluating your own study, these might be the types of data sources that you might want to look into as well for your own work. For reach, we looked at our patient demographic characteristics. For effectiveness, we combined multiple data sources to be able to look at our outcomes. And this was across different health systems. And so we aggregated the data using a common data model. And we were grounded in it's something called the PCORI insight method. And that was the data structure. That was the modality that we used to be able to get a common data structure across all these health systems. They were quarterly depositing data into our data core. We also looked at electronic health record data for additional variables that were not available in that common data structure. We also evaluated patient-reported outcomes, and we did that in a parallel system using a tool called REDCap. For adoption, we really focused on patient interviews and stakeholder interviews for both adoption and implementation. And then for maintenance, we looked both at patient and stakeholder interviews as well as patient satisfaction with the program. So I'm going to talk to you about each of those constructs right now. But before I do, I want to kind of mention a really important part of this study. Once again, this was studied by our Patient-Centered Outcomes Research Institute in the United States. And as part of PCORI, it's what we call PCORI, having patient stakeholder advisory boards is really central. And I really recommend this for all future studies moving forward. In this study, we met quarterly from the design of the study all the way through the dissemination. We met with this group of nurse practitioners, community paramedics. We had patients who were living with heart failure participating in this as well as nurse care coordinators, caregivers, and then program directors, in addition to physicians and the PIs of the study. So this stakeholder board, though, was critical because they gave us very helpful feedback from, like I said, from the design to the recruitment to helping us troubleshoot different strategies all through the process. So let's talk about the REACH. We were really excited about REACH. One of the big challenges in many trials, randomized trials of cardiovascular disease, and specifically in heart failure, is they're not very representative of the patients who experience the largest burden of disease. And that's different with this study. In this study, we had a majority of female participants, 52% were female, in the United States, and I think this is also maybe true in Europe. But there was a lack of representation in many trials. Specifically, there was underrepresentation of Black patients and Hispanic patients, which in the United States experience the highest prevalence of disease. But in this study, 47% of our population were Black participants, 27% were Hispanic, and we recruited patients in multiple languages. Once again, I know in Europe that's probably very common, but in the United States, a little bit less so. We recruited patients in English, Spanish, French, Russian, Mandarin. We really tried to be inclusive of different languages so that was not a barrier to people participating. We also recruited a sample that had a high burden of poor social determinants of health. We know that those social determinants of health, which are very structural, can prevent people from getting high quality care and access to higher quality care. In this context, 40% of people reported not having enough financial resources to make ends meet, and 72% had only completed high school education or equivalent or less. And so this was the population we intended to recruit for this study because we wanted it to be generalizable and we wanted it to be applicable to people who were not participating in other studies, but who need this high quality care. So let's talk a little bit about our outcomes. I'm going to go into some details here. I'm presenting today the co-primary outcomes. The first was health status, and the second was all-cause hospital readmissions. Okay, so firstly, there was no differences in health status between arms when we looked at 30 days. What we did see here, and what's important to remember, is that both groups received an intervention. And so in both arms, we do see this improvement, okay? And this is a clinically significant improvement, over 5 points on the KCCQ, which was our measure of health status. It's called the Kansas City Cardiopathy Questionnaire, where higher points denote better health status on a range of 0 to 100. So in this context, we had pretty low baseline in both groups, and we did see this good improvement. But once again, there was no differences between the two groups. But what was interesting and really important to note was that we had significant interaction effects by age and treatment. And this was an a priori interaction that we had anticipated. We knew that we were going to be doing an analysis by age and sex and site. So in this context, younger patients in the MIH arm had 4.5 points higher health status compared to younger patients in the TOCC arm. So there was important clinical differences here. And what we also saw was that within the TOCC arm, younger patients had 6.5 points lower health status. So something interesting is taking place here where we're seeing that younger patients actually were not doing as well as the older patients, but that patients in the MIH arm, when they were randomized that, everybody improved. There was no differences by age, where we are seeing this differential impact in the TOCC arm. Let's take a look now at 30-day all-cause hospital readmissions. So in both arms, our readmission rate was just over 20%, which is what we anticipated. That's aligned with national averages as well. And there was no differences between the two study arms. But once again, there was a significant interaction effect with sex and treatment for all-cause hospital readmissions. What's important here is that when we look within the MIH arm, within the 30 days, women were 30% less likely to have an all-cause hospital readmission than men. And the question here is, why? What might be driving this? And some of the factors and some of the differences for women were that they were, less likely to have caregiver support, more likely to be lonely. And these were some of so what we think is happening here is that the community paramedics, when they were called in, they were really needed. And it provided that additional support that many of these older women who are living alone needed to not have that hospital readmission. We're exploring that in more depth here in our ongoing analyses, but that's some of our early results. We also have results for our patient satisfaction in emergency department transports. So the majority of patients who completed the satisfaction reported a very high level of satisfaction with their visits. 96% of patients strongly agreed that having a community paramedic was easier than going to the hospital. 92% of patients agreed that the care at home was as good as the care at the hospital. And 96% agreed that they could clearly hear and see the doctor on the video. So this is really important. This is one of the perceived barriers, is that patients will feel like they're not getting as high quality care if that's delivered at home. But that's really inconsistent with how patients report their experience after getting these visits. Very few patients who received an MIH visit were transported to the emergency department or admitted to the hospital. So only 4% were immediately transported following the MIH visit. The vast majority of issues could be handled right in the home and with that telehealth visit. And less than 1% were actually admitted to the hospital. So this is really important to think about how we're able to, a program like this can really shift the cost of acute care into the home, and that the quality of the care can be just as good in the home as it is in the hospital. Now, to evaluate the adoption, implementation, and maintenance, we evaluated that in 2 cohorts using qualitative interviews in addition to the other quantitative data. We interviewed patients 90 days after they were discharged. Once again, we made sure that they had completed, if they were in the study, that they had completed all the endpoints in the study. We stratified them by sex, race, ethnicity, their health system, address in terms of locality, and then the number of MIH visits they received. We really wanted to get a representative picture from their patients. And then we also interviewed MIH stakeholders. These included heart failure doctors, nurses, community paramedics, and MIH directors. And these were not just from our own hospitals. These are really from around the United States. We did these interviews with patients and their stakeholders by Zoom. Our interviews were recorded and transcribed. And then, of course, they were given some money as a thank you for their participation. So of the patients who participated, they looked a lot like the patients who participated in the main trial. 65% were female, 60% Black, 40% Hispanic. 40%, once again, didn't have enough financial resource to make ends meet, and 40% had a high school education or less. And then once again, they were recruited from all five boroughs of New York City. When we look at our national level stakeholders, we included 2 caregivers, 9 program directors, 6 healthcare professionals with heart failure expertise. 8 were MIH staff members who were directly involved in the MIH intervention, including 4 paramedics, 1 dispatcher, and 3 nurse care coordinators. And this is critically important because they were essential to the adoption, implementation, and maintenance of these interventions. These were the 4 states from around the country: New York, Pennsylvania, Texas, and Massachusetts. So now we're going to go into some of the qualitative themes that came up from our patient and stakeholder interviews. So the first theme here was the facilitator of adoption. We're going to talk about facilitators of adoption and barriers. What helped the health system start this program or the patient, and what were the barriers and what were the blocks to participating in it? So this was from a patient. When you have a heart condition and a lung condition, you feel certain things. Like sometimes I could feel the rapid heartbeat. Maybe there's no need for me to go to the hospital. Maybe I just need somebody to check me and say it's okay. This is going on or that's going on, and we can deal with that from the house. This is an example of a patient who really was appreciating the fact that this could be in-home monitoring and providing support for the chronic condition. Another one was avoidance of the emergency department and hospital visits. This is from another patient. It let me know there's other methods of treatment that could be helpful instead of going straight to emergency. Part of it is breaking the cycle, breaking the routine of having worse symptoms and going straight to the emergency department to get that taken care of. This provided a new picture of what is possible in terms of getting care delivered. We started our study in January of 2021, and it went to September of 2024. But in January of 2021, we were right in the middle of the COVID pandemic. And actually, January 2021 was right when New York City was really at the epicenter globally of the pandemic. And so this was a component to the study that was challenging, right? It made recruitment challenging, it made retention challenging. And there was different pictures of how COVID impacted it. Okay. So on one hand, it reduced patients' exposure to COVID, right? Because they didn't have to go back into the hospital at a time when many people were really terrified of going to the hospital. And so, here's this patient saying, it was awesome, right? That I could have somebody come right into my home to do my EKG and take my pressure and my weight. And then on the flip side, we had other patients, and I can talk about that as a barrier to adoption, who were concerned. They didn't want to expose family members to having paramedics who may have been exposed to COVID to come into their home. So this was both a facilitator and a barrier. It expanded clinical support through MIH providers. This is important. This is coming from a clinician who's really saying, I only have so much time in a day, right? If there's an external team as an extension of mine who can increase the physical touches with patients and support the patients, keeping the fluid off, managing diuretics, and keeping them out of the hospital, they were really supportive of it because it expanded limited resources that they have, okay? Another clinician said, sometimes we have patients in crisis or needing extra support. This bridged the gap because we don't have a clinic and sometimes patients can't get to their doctor, okay? And this is really what this program was about, bridging the gap, providing that transitions of care support. Another facilitator was the strategic partnerships to support and launch these MIH programs. This is really about bringing programs together in an institution, bringing the resources together to start something new. In this case, I think ultimately the approach that works at a large institution is being very collaborative, making sure you're engaging key people in the organization that have potential influence over your area. And I think this is really true probably for adopting any new intervention in a large institution, right? It's all about bringing the key people together in an organization who have influence. And that was certainly what facilitated the adoption of this program at this institution. Another facilitator for adoption was the policy and regulatory flexibility during COVID. Once again, some of this was very time dependent, right? It was a very specific time during COVID, kind of globally. But at this time, COVID allowed a mechanism through the hospital without walls program for us to generate revenue of services by paramedics in the home setting and non-transport capacity. So it opened the administrator's eyes on the hospital at home. And once again, a lot of this comes down to everybody has a different regulatory environment, and that's very specific to your country, to your immediate locality. But you want to think about what are those policies and regulatory flexibility that you can use, right? That you can use to your advantage in terms of interventions like this. Or what would be the areas that would be the barriers? And this is once again another significant barrier around financial incentives. Who's going to pay, and who and what who has the incentive to really be investing in this? And value-based programs or more centralized kind of payment structures help facilitate that more than a pay-per-service. So that's one of the challenges that we have in the United States. But once again, that is going to be a different challenge that to many of you who are coming in from Europe. But financial viability is critical to the both implementation and the maintenance and the adoption. Complex regulatory considerations were also another barrier. In our country, EMS has a lot of regulation and scopes of practice tend to be limited. It's highly variable from state to state. Most places legislatively haven't caught up with the evolving care models, and there's no reimbursement for a lot of these. And so this is another reason why continued and ongoing policy engagement is really important as we think about these regulatory environments. Okay, so that was really our focus on adoption. Now we're going to turn to implementation. Implementation is really focused on understanding variability across sites, across workflows, and resource availability. MIH here included home visits, telehealth, and coordinated follow-up, but it was implemented slightly differently in the two health systems. And that's part of a pragmatic trial, right? Is evaluating that and understanding what are the similarities and what are the differences, what works well and what doesn't. And so some of the flexibility of the MIH enabled real-world adaptation, but it also impacts heterogeneity in terms of delivery. For this implementation, we both looked at our log files of who was reporting these visits, and we also looked at our interviews for that. So I want to start off with looking at utilization, right? And when we're thinking about implementation, utilization is central to that. It really varied widely, right? Some patients receive extended support over several months, and some patients didn't access the program at all. And I want to acknowledge that. Some patients who were randomized to the mobile integrated health group did not take advantage of the intervention. Either we couldn't get a hold of them and we were not able to follow up with them after multiple calls and attempts to be able to reach them, or the nurse care coordinator would talk to them and they would say, I'm going to decline a visit. I don't need a visit. Or in talking to the patients, the nurse would decide, hey, you're really stable and you have all the resources you need. You don't need a visit right now. So there was a couple different mechanisms for patients to decline the visits or to not get a visit. But that did, make a difference. So the median time in the program was 1 month. Once again, the real focus of this is that bridge from the hospital to home. And so the focus is in that first few weeks after discharge. This is not intended to be a very long-term program. It's really focused on that intermediate, that post-discharge period. The median visits was 1 visit. The mean time of participation was 4.4 months, and then mean visits a month was 1.5. So some of the predisposing factors, and I'm going to talk about predisposing factors and enabling factors for implementation. The first was leveraging EMS skills and knowledge. This quote here really gets at the importance of having paramedics with strong expertise, really good experience. They modeled the expertise, the pay rate experience off of the flight program because they really wanted paramedics who could act independently and were really going to be, a strong advocates for this program. The second predisposing factor was this growing digital health infrastructure. And this is, we were doing this and evaluating this at a time where there is broad adoption across the whole healthcare system of using different types of digital tools to be able to reach patients and to close those interclinical gaps, right, between hospital and home. And so this has really helped to enable, as this says, higher quality care in the digital space. Another predisposing factor was institutional support. And this is absolutely critical. Without executive support for programs like this, they just will not work. They will not get off the ground. And I like what they said here. This MIH director said, faith, investment, coordination across departments in a big health system, and reputation are 4 areas that have helped us continue to grow upwards. So this is really an important predisposing factor, is having this strong institutional support. As you could see from that video, the patient really trusted the paramedics. There was a very affable relationship between them, and you could see how congenial it was. And this was really important for those patients to trust the paramedics. And this is just an example from a patient. I thought if anyone was going to go through what I went through that day, they wouldn't be going to the hospital as much. And I think this is really telling, right? The patients say, I want to stay at home. I want to get that care at home. I don't want to have to go back to the hospital and go through what I have to go through when I go to the hospital. A big question is, does the telehealth functionality work, right? Are people able to have a clear connection, and really, does that work well? And I would say yes. By the paramedics going and bringing in the technology into the home, making no assumptions about patients' broadband connectivity or other devices, that really helps facilitate these telehealth visits. Now, let's talk about some of the barriers, because there are some very real barriers here. And some of them are not having the patients call and access the nurse care coordinator when they need to. A lot of it is proactive right now, with the nurse care coordinator calling patients. But what we need to do better and figure out how to close the loop better on is educating and helping patients know that this is the nurse care coordinator that they should call when they start having decompensation. We give out our numbers on a piece of paper and they seem to not remember how to find it. We need to do better than that, right? We need to figure out better ways of communicating with patients and getting them access to this when they need it. Another implementation barrier is the workflow and the logistics, right? How do you handle referrals, right? Do you have a 24/7 phone line, right, for transport and for picking up the calls? Do you have an ambulance company we're affiliated with? Can the company take on additional workload? What kind of vehicles are you going to use? Buses? Are you going to use SUVs? Are you going to use the ambulance? What are you going to use? So there's a lot of questions, important questions about resourcing, workflow, and logistics. And that these are real challenges and barriers that we needed to overcome in this. So now I want to talk about maintenance. Is it sustainable? And this is really important. And I think one of the benefits of being able to evaluate 2 programs that were ongoing in a hospital is that we were able to evaluate it, but now it keeps going, right? And then we also have the opportunity to improve it, to provide feedback back to it, to do things better. But they're not stopping. We had research team members who participated in the evaluation, but it was all of the clinical care providers who were actually delivering the intervention. The nurse care coordinators were delivering the intervention, the paramedics delivering the intervention. So because we were able to use real healthcare professionals, this hasn't stopped now that the evaluation is done. And what we found here was that the vast majority of the participants highly rated the program a 10 out of 10 with a mean score of 9.5. Meaning that they would recommend the program to a friend or family member. And that really shows that they appreciated it. Why? What are some of the reinforcing factors for the maintenance, for the ongoing sustainability? It demonstrated value and sustainability. They see the value we bring. ED avoidance is somewhere on the average of between $1,000 and $1,200. So healthcare plans hear that number and they're much more likely to sign contract with NIH programs. Yeah, there is a very significant cost associated with just transporting patients back to the hospital again. And then really we see this as part of future innovations and improvements of really trying to provide high quality care in a different way, connecting the technology and infrastructure to provide care for a patient that needs it, and to do a way to do it, the reimbursement that would be a successful model. So what we really are trying to figure out next is what are the different policies, right, that we can change to be able to facilitate the reimbursement, to have that be more seamless, because that is one of our big barriers. But our reinforcing factor in these institutions is that we've been really able to provide high quality and value to care. Patients have really positive experience, which also really supports reputation of the hospital systems. In an environment where you have to travel at least 40 minutes to get to a hospital, right? Having a paramedic come to the home who can be dispatched from anywhere is well worth it. So this is from a patient perspective, they really appreciate it. Now, some of the barriers to the ongoing nature of this is limited EMS staffing capacity. We really saw this, especially post-COVID, where, the emergency medicine paramedics were really burned out because of the trauma that they had experienced. And so there's staff turnover, right? And so kind of making sure to have enough capacity to be able to do both traditional EMS work as well as this community paramedicine work is really important. And what we'd like to do is be able to have more service for this and to be invest kind of more in this because the demand is really high. And then once again, I touched on this before, but a real barrier can be the regulatory and policy landscape. And so, I like this. Back in the 60s, when EMS was set up, it was the days of an ambulance driver. Now EMS is doing medical care, making diagnoses, giving appropriate care in the field that's life-saving, and the patient doesn't need to go to the hospital. And so currently the reimbursement is still for transporting back into the hospital. And that's what needs to shift to be able to kind of be more aligned with our current environment. So that was really the focus of the re-aim evaluation of taking our intervention and breaking it down into looking at those constructs. The other thing that we also did was we applied the CFR framework, the Consolidated Framework for Implementation Research, to design a paradigm of change and to really think about the individual and organizational and policy level themes. And so some of those higher level kind of themes I want to just briefly touch on. When you think about the individual level behavior change for members of the teams, these are some of the areas that we felt like we could strengthen in terms of future implementation. Continuing to catalyze these interdisciplinary partnerships, engaging stakeholders across all levels, and that's both vertical and horizontal stakeholders, optimizing workflows and MIH program referrals, prioritizing patient perspectives and experiences, and then continuing to make telemedicine more accessible. And once again, we are doing that, but we want to continue to make it even more accessible. Now, when we think about the collective level for change for teams and organizations, here are some other factors. Considering flexible staffing. This is when we think about this is both in the context of the paramedic personnel, as well as our nurse care coordinators and our physicians. Prioritizing this as a mechanism for healthcare delivery, sustaining utility amid the change, right? Amid the changing policy landscapes and changing, even changing of political administrations can really impact reimbursement. And then continuing to foster innovation in a value-based system and not just thinking about that fee for service. And then building strategic cross-sector partnerships. And then finally, I want to think about the structural level. We've talked quite a bit about the importance of policy and reimbursement, but these are some areas to address regulatory barriers, to help ensure timely transitions, demonstrate cost effectiveness, leverage state and federal funding models, and then finally, really designing programs for equity and inclusion to make sure that patients that have the highest prevalence of disease can access and benefit most from it. And with that, I would love to open it up for questions. And I'd like to acknowledge these are the members of the Mighty Heart team who've been so committed to this work. We have collectively invested 4 years into this and are really excited to see where it is now and to see the way that the study is helping to evolve the program and really improve it for the future. So with that, I'm going to just stop sharing and I'd love to open for discussion together.
Thank you, Ruth, for that wonderful, wonderful presentation. It's great to see all the work that you and your team are doing. And yes, I think we've already got some questions in the chat already. So to kickstart us with some questions, we've got Sabina first. So Sabina, did you want to ask your question in person?
Sure, I can do that. So I'm Sabina Dries, University of Basel, and Dr. Masterson Creber, I really would like to congratulate you on very important work that has huge relevance for cardiovascular care. And I have two questions I would like to discuss with you. First is, you really did a very comprehensive evaluation of your pragmatic trial. And so for me, from an implantation science design perspective, this was a hybrid one trial. You do a trial and then at the same time you observe the implantation. So what could you suggest to improve in the next study? And the second question is based on your excellent exploration of barriers at different levels of the system. Have you and your team already thought about implantation strategies to overcome these barriers? And that also could inform, future studies in your setting, but also if you think about implantation of this intervention in other settings. So it's more a question of deepening the insights you got and looking into the future, what could be learned and how we could strengthen them potentially in a hybrid too. Or I don't know if you think about the hybrid tree. I mean, it's just, I would like to know your thoughts about this.
Great. Well, thank you for, this is an exciting conversation because I will be totally transparent. The results of the study were just actually presented for the first time at ACC at the very, very end of March, and the paper is actually under review right now. So this is all hot off the press. And so this is a great time to start thinking about implementation for next steps. But really, we're early, right? Because we're still kind of analyzing the data and trying to figure out what worked best and for whom. And so I would say, one of the areas that we are really looking into more, and one of the barriers was something I alluded to, which was the challenge of having patients get discharged and then being able to reach back out to them. And we know that this is a problem for both the transitions of care coordinator group and the MIH group, where we have nurses who are making calls, trying to get in contact with patients. But I think especially many of our patients who have this high burden of poor social determinants of health and don't have a lot of support, sometimes it can be very hard to get in touch with patients. And, their phone numbers change, or any unknown numbers are blocked on their phone, or they don't check text messages, they don't have email, right? So many modalities that we might use with our colleagues or friends, are not the same modalities that we're able to effectively use to communicate with our patients. So one of the strategies that we're thinking about considering kind of moving forward is for that the most vulnerable patients is to think about how we can utilize community health workers. We have very active programs with community healthcare workers who are people from our community who live in the community, who know the community or from the culture of the community, speak the languages in the community, and that they could potentially help us be a liaison where they can be a trusted person who can actually follow up with patients. And it might not be on the phone. It might be going in, knocking on the door and checking in and seeing how they're doing to help them get connected. Because we really have trust barriers as well, right? Sometimes people don't trust someone coming into their home. They are uncomfortable with that until someone who they do trust, helps break the ice and help them to see that this is a program that they could really benefit from. So those are some of the types of things that we're thinking about in terms of our next steps, is getting a little more innovative and not making just kind of assumptions that, people are going to pick up the phone and it's going to be easy to follow back up with them, which we didn't make that assumption, but the study was structured that was actually an important kind of mechanism for contacting patients, and that ended up being harder than we expected. I could go into a lot more, but maybe I'll go to the next question. We can maybe circle back if we have more questions on that, if that's okay.
Thanks so much.
Wonderful.
And good luck with the next steps.
Thank you.
That's great. So we've got 3 questions from the next member of so the first question is, did you measure at what interventions were delivered as a response to the assessments, such as example, focus on guideline directed medications? I'll maybe ask them one at a time, or yes. And go ahead.
Yeah. So actually, yes, we did. And one of our quality measures in this study is actually adherence to guideline-directed medical therapy at discharge. We have not analyzed that one yet, so that's kind of forthcoming as a secondary outcome, but that's certainly something that we did incorporate.
And the second question was did you look at the economic value of the intervention? Further, maybe also to add on to that, were there any investigations into the implementation costs that such a delivery, how much it cost to actually roll out such a service?
Yeah, great question. So we have access through this study to Medicare data, but there is a lag in terms of, and Medicare data is our claims data kind of across the United States for adults over 65. So that's going to include all costs for patients kind of over 65. There is a lag in terms of kind of when we can access that data and get that data. So we are still waiting for the final kind of cost data to come in, but we will be looking specifically at that question. But I do want to direct you to a recent New England Journal of Medicine Catalyst paper that was published by Dr. Brock Daniels. He and I are MPIs on this study together, but he really leads the operational side of this. And once again, this was an evaluation of an ongoing intervention, which is taking place across a hospital in a much larger cohort. So you can kind of think about, the whole interventions, like the whole program is like this, and kind of I was doing the evaluation of a specific part of it in patients with heart failure. But when we look more broadly at the cost savings of this intervention, what we do see is a shift in the cost from the acute care environment to the community or to the home. So it doesn't necessarily reduce costs, but it does change costs, and it makes those costs much more aligned to patient priorities and values, where they would rather have resources being spent supporting them in the home or supporting their caregivers in the home rather than in the acute care environment. So, but I would recommend reading that New England Journal of Medicine Catalyst paper for more details.
Wonderful. And the last question from Petra Schaefer is, what is your recommendation for transition follow-up for people with heart failure ongoing versus when to stop the follow-up?
Yeah, and that's a really important question. And a lot of this is something we've really been wrestling with, right? Because I'll give you the example. We have one patient who loves this program, and she's been part of the program for years now. And she says it's totally saved her life. She talks a lot about how this program is really what has prevented her from dying. And so once someone gets access to a program like this and they really feel like it's completely life-saving, we have continued to allow them to have access. Now that's not a lot of patients. Many patients are like, no, I think this is good for this transition. And then they get back into their routine with their primary care provider or their heart failure specialist doctor, and they're able to, carry on getting that specialty care that they need. But once again, that's not everybody, right? You have some patients who really don't have that close collaboration with the primary care provider or cardiologist, and they just kind of need this adjacent support. So I would love to say there's a one size fits all, but I would really say it depends, right? It really depends on the healthcare infrastructure that's there, the complementary resources that patients have access to, and then it also comes down to some of those individual level factors for the patient themselves.
And so we have one more question. So from Karina Shonwis. I'm not sure, Karina, would you like to introduce yourself and ask the question yourself?
Yes, thank you very
Yes.
much. Yes, my name is Corinna. I'm a student at the University in Basel, a master student. And can you maybe just say some few words about the development of the intervention and how you involve the patients in its development?
Absolutely. And so in terms of the actual intervention, that was developed within emergency medicine, and that's kind of evolved over time. So once again, we involve the patients, from my perspective, in the evaluation, in the kind of how we structured the evaluation of this intervention. But my physician colleagues could speak more to how they involve the patients in the actual development of the clinical component, if that makes sense. But the way that we involve patients in the development of the evaluation of these two is that we really sat and talked to them about what matters most to them. What outcomes are important? We are funded by the Patient-Centered Outcomes Institute that cares about patient perspectives and cares about developing science that can help patients make an educated decision between different types of interventions. And so in this case, we really want patients to have the evidence to say, I want program A or program B. And so that's what we've done. But they needed that with outcomes that matter to them. And so in our situation, we chose, and they said, my health status matters to me, right? I want to be able to function. I want to be able to have control over my symptoms. I want to be able to participate in social roles with my family, right? And my friends. And so we wanted to make sure to pull those in. And that's why we had a co-primary outcome. It was we wanted to both reduce hospitalizations. We know that cost and quality matters, and hospitalizations are part of that. But what also matters is that patient experience, and that patient experience of their of being able to take control back of their own health condition. And so that's how we brought the patients in. And then we also talked to them about and brought back like all of our materials, our patient recruitment materials, how we framed the study to them, how we talked about the study. All of that was discussed with our patients and stakeholders so that they could say, oh, wow, I would change how you're talking about it. And we actually had one caregiver who goes, what are you talking about? This is a concierge service for patients. Like, say that now. So we didn't quite say that, but it was interesting to kind of get that perspective of, sometimes we're explaining something very scientifically, and the patients and caregivers would say, speak in plain language, speak in ways that make sense. Say it like this, and that's what was really helpful to get that input from them.
Thank you.
Yeah, you've made a really important point, because often the language we speak is not the language the patients speak. So it's really important to involve them in the whole process. Perhaps maybe you can comment on, so you mentioned before that you will be collecting Medicare data. In the US, is this something that's linked, and can it be readily accessed, or do you have to ask patient permission to access this? And maybe what was your experience with patient data sharing and maybe their perspective? Because we've had in our projects, we patients are a little bit hesitant to share this sort of data, and it's quite important for us to generate this sort of evidence. So maybe you can comment on your experience or patient experiences with data sharing to collect the study data.
Yeah, that's an incredibly important point, and absolutely something that we think very carefully about, because we know that impacts patients' willingness to participate in studies, that impacts their trust, right, in researchers and healthcare providers, and so it's really important. So we, in terms of getting access to the Medicare data, it is a lengthy process, and it's very, very tightly controlled and managed, both from the cost of it, as well as the regulation required around how you can get access. So you end up having, kind of one seat that you pay for, but you have to go through a lot of training to have your one statistician go into their data environment. So data is not transferred, their data is very, very secure. And so I just want to be very clear that there's no kind of data sharing regarding that Medicare data. The vast majority of the data analysis that I shared with you today, actually all of it, was done in our own secure data service and our data core, not with Medicare data. But in terms of patients' willingness to be able to provide consent, we are very clear with them in the consent form of how we're going to be using the data and what we're going to be using it for. It's only used for the purposes that we explicate in that informed consent. And that is, that is all that it is used for. This is not, shared with any other external recipients on anything. So we are very, we take the security of our patient data, and we take the highest, we're very, very careful around all of our patient data.
Oh, that's good to know. That's good to know. We have just another question. Oh, perhaps just to repeat the author, the name of the NEJM paper, that the Catalyst paper you mentioned.
It was Dr. Brock Daniels.
We
Brock,
can
yeah,
share that with the team.
definitely. Yeah, and be looking out. It hasn't been published yet, but hopefully the results of the study will be coming out soon. We'll keep you posted on that.
And I think we kind of touched on this with the questions from Sabina de Guess about what's kind of coming or what you have planned to improve for next time. What's kind of next for the Mighty Heart team? So what is there plans to scale up? Is it still in the works to kind of just review the current barriers and deal with those first? Or is it planned to kind of expand out to other hospital settings and things?
The plan is absolutely to be scaling up and to be scaling to different patient populations. We're also really interested in collaborations with rural environments. We know that, while there are access to care issues that we have in the urban environment, there's also, huge access to care in rural environments. So we'll need to look a little bit different, but we're really interested kind of in expanding in our collaborations in the rural settings. And then in terms of other disease populations, that's another area that we're really interested in expanding and thinking about how this could work with palliative care and how this could work for children with serious complex medical needs, and a number of different patient populations that we would consider are high need and high utilizers. And so those are the patient populations we want to reach with this program.
Really great, and it was great to see that the reach that you had, so you were able to access the minority populations that aren't always represented in research. You mentioned language, but was anything else done to really get this wide representation amongst your cohort? Was it purely, do you think, language, or was there any kind of other strategies or other tactics used, I suppose?
That's a really important question. We were very strategic about it. And another really important thing was the team, right? That's recruiting and actually interfacing with the patients. And we really wanted to make sure that our team represented the patients that they were recruiting. I think when a research coordinator can walk in and the patient can have a level of trust that they're from the same community, that they have shared experiences, that changes the type of trust that you have, even in hearing about the study, long before signing an informed consent. And so I would say that was an important part, as making sure that there needs to be strategic hiring decisions around making sure that the team represents and looks the same as the patients who you want to recruit into your study.
That's really important. We have a new entry, so we've got one more question we've got a question from Cherie Kashuba. Did you want to pop online and ask that question, Cherie?
Thank you. I think I'm Cherie Kashuba. I work for Acute Care Alberta in Canada. We're responsible for acute care services across our province and have just been stood up at the beginning of April. Super exciting work, and I have the pleasure of working provincially with both cardiovascular providers and emergency providers. And so the synergies are incredible. And I see many more opportunities. So I think you were already addressing my questions in terms of looking at other populations, substance use and mental health concerns, often integrated, but not always, are particularly a big area. So, and it's obviously different than a particularly focused, more medical condition or disease. So any discussion on that front?
Oh, Sherry, you're bringing up some great points. And I just want to say, some of the most innovative models of mobile integrated health are from Canada. So that's, and you guys are really ahead of the curve in terms of doing this. And so we have a lot to learn from you and your experience there. It's actually, I think it's a great question around the expansion of mental health. And this is something I didn't actually put out the exclusion criteria, but we did exclude people who had diagnosis of dementia, as well as kind of any kind of active psychosis or kind of active substance use. And I want to acknowledge that, right? Because we know that these are actually patients who could really benefit from this program, but we also had to kind of weigh the risk, right, of sending our paramedics kind of into environments where there could be a level of instability, right, that they may or may not be equipped for. And we wanted to make sure that before we did that, that we really would have given them kind of specialty training in that. So the one thing I would say is I think that there's so much that we can do in these spaces, but it does require, I think, some additional, specialty support and training so that they understand how to kind of manage what could be an unpredictable situation. And I'll just say that, we did that for these community paramedics in terms of additional training in heart failure. We had them go through a number of different case scenarios and work with a heart failure cardiologist to kind of get that additional training. But I would just say we would need to do the same if we're to expand. So maybe do you want to comment on that? I'm curious. There's probably things we can learn from the Canadian experience on this.
Well, I have no specifics, but your comments about going into environments where there's a degree of uncertainty and potential safety. I mean, we certainly are doing work around how to prevent harassment and violence, mostly focused on emergency departments. And we are also in discussions with our emergency medical services colleagues, super aware that they're going to a destination, not necessarily a patient, and the context within which they are needing to provide care is very different than the confines of a emergency department where there are security services, there are other people around, there are more of those, what I'll call wraparound security. So we have, to my knowledge, at least in Alberta, and I'm not the expert on the EMS front at all, so just putting that out there, we have lots to learn and to look to colleagues like you and around the world to see what advancements and opportunities there are to support both the training, the safety and the environment, and the care of these vulnerable people.
Absolutely. Absolutely. Well, great. Well, I'm glad we're connecting here, and let's continue the dialogue.
Okay. So there's no more further questions, but please, if anyone has any further questions or topics, please feel free to put up your hand, raise your hand, or enter them in the chat. Maybe just a question. I think it's maybe more so from my perspective, because we work a lot in pharmacy health services and how pharmacists can help support long-term chronic care management for patients. Perhaps if you can comment on if there's any, you believe there's any room for, I know that the Mighty Heart is more for the the kind of the initial parts of transition of care, whether there's any room for pharmacists to be integrated in more of a long-term kind of care plan.
Absolutely. And I think that what we know is that one of the big triggers, right, for patients to come back into the hospital is not having access to the right medications or that med reconciliation process, getting prescribed new medications when they're in acute care and then going home and then having all their old bottles of medication and getting confused and not knowing what to take now is really important. So one of the most important things that the community paramedics do when they go into the home is do a med reconciliation. And I think that's critical. And then being able to liaise directly, I think, with a pharmacist to support the med reconciliation would be very valuable. A couple other pharmacists have actually reached out to me as well about this and said, you know what, I think there's so much room for pharmacy services to come in here as well. So I think that that's a real area for kind of innovation. I think we just have to, you know, a lot of this comes down to really thinking through the reimbursement for this, right? And like how can, you know, how does all that work together? But I think there's certainly a lot of opportunity.
Wonderful. It's good to hear. That's good to hear. Okay. Let's have a see. There's no further questions from the members of the audience. Perhaps, I was trying to go through kind of little notes that I put down. I think you said that the mean number of follow-ups was, median number was 1. The mean number, I think, was 1.5. What was the maximum number of follow-ups that people had in this service? Was there a maximum where they kind of said, well, this is no longer in our scope. You need to go back and see your specialist or hospital?
So we did have like 1 or 2 patients who did have a lot of visits over, not in a short period of time, but like since the start of the program, they have routinely kind of used the service. And once again, I think it's for them, I think it's prevented a lot of hospitalizations. So that kind of pushed up our mean a little bit because we had a handful of patients, but we actually on our health system. In the other health system, they didn't have, once again, the same program was operationalized a little bit differently, and that was just because of how the clinical workflows worked. But they didn't have the mechanism to be able to do multiple visits. So in one health system, there could be multiple visits. Usually there was one, but there is the potential for multiple, and a handful of people did access them multiple times. And then in the second healthcare system, there was not. It was one visit. It was only ever one visit. So once again, some of that has to do with just how things got operationalized.
Yeah, you mentioned there was a bit of heterogeneity in the way things were operationalized between the paramedics. Would you consider, was there any kind of attempt to measure the fidelity to the intervention throughout the service to kind of understand what was done differently, what were the big differences, and yeah.
Yeah. So I would say if I was designing it all over again, that would be one area that I would pay more attention to, or kind of think about how to kind of evaluate that meaningfully throughout. We did measure it. We did look at, we looked at all the documented interactions with patients, because all of those are documented in a consistent electronic health record system. So a lot of that went down to kind of how do we use, natural language processing to evaluate notes, or to, kind of qualitatively also kind of look through notes and look at what was discussed and how it was discussed with patients. But there was, I think there was still some things that we would definitely do a little bit differently in terms of kind of tracking that more or earlier, I think, in the intervention.
Wonderful. That's really great. So I feel if there is no further comments from the audience, we might kind of wrap up today's session a little bit earlier. But no, really, thank you so much, Ruth, for you and your team. Your work has been really, it's great to see how such an intervention can be created in terms of a more patient-centered manner, and how it can be rolled out in such complex environments. So it's really great to hear about your work, and we eagerly await all of the publication that comes out so we can see more of these results and to see what comes next for the Mighty Heart team. So thank you so much again for joining us. I suppose I will just share a few impact-related notices for the people that are still online. So I'll just quickly share that. Where are we? Okay. So just a reminder that the third Impact webinar will be taking place on the 17th of September. I'm sure everyone can see that. So 17th of September, and we'll be hearing from 2 researchers. So we'll hear from Pan Nielsen, who'll be discussing artificial intelligence, looking at implementation in healthcare and lessons learned from implementation science, and also from Dr. Julian Hong, who will provide a clinical example of AI implementation in cancer care. So looking at opportunities and barriers in that space. So we really hope to see everyone back there, back here again in September. And also, if you wish to review this wonderful webinar again, so the webinar will be posted in the coming days to this link. So if you wanted to scan that and save that, you'll also receive an email with the webinar link. And further, in terms of impact news, as you all might know from previous webinars, we will be having an in-person impact conference in Zurich in February 2026. So we really, if you want to get on the mailing list for that, information and registration will be coming soon. So it'll be wonderful to all meet in person, hopefully in Zurich next year. So many thanks again for everyone for joining tonight, and thanks to Ruth again. And yes, if there's any feedback or feedback from the audience, or please feel free to send them to the Impact support email. So many thanks. Thank you so much, and wishing everyone a lovely afternoon and night. Okay.
Thank you for joining us.
Thank you. Thanks.